Hello everybody, welcome to another episode of IBD Essentials. Recently we just got a lot of likes, and it would be really happy and appreciate if you would get us some more likes if you really appreciate our channel and our interesting topics. Today I meet with a great colleague and friend from the other part of the world, Taku Kobayashi. He is from Tokyo, and it's a great pleasure to meet you today. I think the healthcare systems are different between Europe, US, and Japan, for instance. But before we really go into the topics and matter, it would be great if you could introduce yourself and just say a little bit why you also ended up to do IBD and not, for instance, cardiology.
Okay, so first of all, thank you, Axel, for having me in this wonderful the opportunity. And my name is Taku Kobayashi. I'm a director of the Center for Advanced IBD Research and Treatment, Kitasote University, Kitasote Institute Hospital, which is located in the heart of downtown Tokyo. So the reason why I'm doing the IBD is actually, to be honest with you, my father is kind of the first generation of IBDologists in Japan, like many years ago. So I certainly received the influence from my father. I studied medicine, and I started interested in GI, and then he actually basically guided, and my previous mentor actually guided me to do IBD, and I started the research in IBD, and I moved to the United States and doing the basic science in the field of mucosal immunology at University of North Carolina for 3 years, and then came back to Japan doing both clinical and basic sciences at Kitasote University, Kitasote Institute Hospital.
Yeah, this is a very interesting way. Just recently I was talking to Bruce Sands, and Bruce Sands and myself shared the same bench when we were at Massachusetts General Hospital, and you also did the way to go to the US, and you also did real basic research and then also became a clinician. So I think this is very exciting. Today, I would really like to discuss several topics with you because for a lot of us, Japan seems to be far away. And we see always the Japanese as so kindly, friendly, knowledgeable people. But we also believe that there are, and when I was talking to you and also talking to other colleagues, that the healthcare systems are a little bit different compared to North America and to Europe, for instance. So perhaps you can explain us a little bit the setup of the healthcare system, and especially then the IBD healthcare.
So in Japan, one of the most important characteristics of our healthcare system is the insurance is completely public. That means everybody has 100% of us have the same insurance, which actually covers 70% of the medical expense. But the medical expense, all the prices are determined by the government. They're completely flat everywhere, and it's very cheap already. But again, the public insurance covers 70% of it, so that the patient only have to pay 30% of the cheaper, the price for medicine or for procedure, for hospitalization, the healthcare there. And what's also unique to IBD patients is that there is a extra medical subsidy for IBD patients once they are qualified for the refractory diseases. That there's a refractory disease specific medical subsidy, which actually covers more than that 70%. So the most of the patients only have to pay around 50 to 100 euros maximum per month based on their income. So the vast majority of the medical expense is covered publicly.
This brings me to one question, because not everything is invented in Japan and something is coming from overseas. So how can your government convince companies to have a certain price and to accept this certain price? Because you said it's the same price all over the country. and it's fixed by the government. So if there's
Yes.
something, a new innovation, at least in Germany, I know the prices are always very high, and after 10 years or 15 years, when it goes out of patent, it becomes cheaper.
Yeah, so the prices of the drugs actually gets gradually cheaper over time, but the initial price is actually determined by the the existing drugs like
Okay.
in the similar class. So the second anti-TNF, the price was set, that determined completely matched with the first anti-TNF, for example.
And how is GI done? So, how are the offices based? Is it all based at hospitals and outpatients and inpatients at hospitals, or do you have private practices, private offices for especially you mentioned complex IBD, and there is also a different payment. How is this set up?
So of course we have private clinics and the usual hospital-based the clinics and the hospital wards as well. But regardless of which hospital or which clinic the patients are seen, the medical price is completely the same, regardless.
Okay, and another important issue is probably how do you collaborate with colleagues? So we always talk about the MDT groups, so multidisciplinary teams. Are they based at the hospitals? And other question also going along with this, how is the access for the IBD patients? So Tokyo, I assume there are 100 hospitals, and the patient has it easy to do it, but in the more remote areas in Japan, do they have to come to Tokyo, to Sapporo or other big cities, or do they have local facilities?
Yeah, so it really depends. But Japan isn't that huge country, and there are like several like big cities. So there is a trend for the IBD patients, especially because these are the refractory diseases. So the most of the patients want to be seen by the experts and specialists, mainly in the like urban areas. But again, anyway, the prices are exactly the same regardless. So
Okay.
that's also the reason why the patients always want to be seen by the experts.
Okay. And coming back to the MDT team, so are you organized in a similar way like the ECHO recommendations where we say you should have a surgeon, you should have a pediatrician, nutrition, psychologist, and so on? Or how is it the setup
Yeah, so
in
like our
Japan?
center has our own like MDT, the MDT team like designate for IBD, but it's typically quite difficult in Japan because all the nurses and the pharmacists and dietitians actually have to rotate among the department. So even if they educate and train our nurses, then those nurses may actually leave GI for like dermatology or like OR, ER. So it's quite difficult to have the fixed MDT.
Okay. Moving to the center of our daily work, the patient. So, is there, or you have been in the US, is there a difference in the physician patient relationship compared to North America or to Europe, or is it exactly the same?
Yeah, it's very different in probably two ways. One is that, as you can imagine, like Japanese patients are quite modest and quiet, so they are very adherent to like what we say to them. So, and the other difference is that probably partly because of our healthcare system, we can't really spend that long time per each patient. Like typically in my clinic, I have to see more than 30 patients in one single morning. That means I can only spend like five to like 10 minutes maximum. So we can't really have very deep conversation with the patient. So that's also another difference between us.
It has just recently become very important to get the PROs from the patients, so quality of life, urgency. So how do you get this information? Do you use questionnaires before? Do you have computer aids? Or how do you get if the patient is doing well if you have only 5 minutes?
Yeah, I think in our center, we have my fellows or my nurses just to see the patient before I see them, like to have them like score like
Yeah.
CDAI or like the Mayo scores, including the PROs.
So then I would like to move a little bit to the strategies of treatment IBD patients, and also then perhaps going a little bit to therapies. And we know, according to STRIDE and everything, monitoring is very important. How do you monitor the disease activity of your patients? What of the numerous tools are used in Japan or in your personal practice?
So in general, in Japan, the access to endoscopy is quite easy. As you can imagine, that Japan is kind of the country of endoscopy. So there are many like endoscopy companies that are coming from Japan. So the access to endoscopy is quite easy. And that's why a lot of physicians, even in the IBD, including IBD experts, just tend to use and like prioritize the use of endoscopy quite easily. But whereas the access to ultrasound is still limited. But in our center, like we have the multiple people, they are doing the IUS, like 2 physicians and 3 like ultrasonographers doing IUS for like IBD patients. So we are like moving toward non-invasive monitoring, including IUS and the fecal calprotectin. Another difference unique to Japan is there is a new the serum biomarker called LRG, which leucine-rich glycoprotein, which is reported to be more sensitive than CRP. So we are getting more and more like using that biomarker as well.
Yeah, I think this is very exciting. When I was attending the last Japanese GI meeting, there was like a full session just about allergy, and we are at the moment also trying to evaluate and to establish this in a European cohort to see, because it looked really, really impressive. But let me move a little bit backwards to endoscopy, because here in Europe, I heard sometimes from colleagues, it's very difficult to get an endoscopy to monitor the patient, to follow up. For instance, we have in our guidelines, you should have a colonoscopy after surgical resection in Crohn's disease, and there is the 3 to 9 month frame, and they tell me, oh, it's almost impossible to do it. So
Really?
how is not in our center? I'm always amazed because I would do the colonoscopy myself, and I can tell I would like to make the colonoscopy next week or sometimes if it's needed. So how is it getting access to colonoscopy?
Basically, the capacity is like plenty because the almost all the gastroenterologists like scoping the patients. So there's a lot of space and room for the patient to make the appointment for the endoscopy. And Japanese patients are patient enough.
Okay.
And they don't really dislike the colonoscopy. Of course, they prefer the less invasive the ways, but we don't really see that huge difficulty in like convincing the patient to have a colonoscopy or an endoscopy.
Okay. So for the rest, I would like to talk a little bit about treatment and perhaps also treatment differences. I always see when something is big clinical trials are done, there's always a subgroup from Japan or at least other Asian countries, sometimes even a repetitive study in the Japanese population. Are there differences in the response to certain treatments, or what is the reason why this is done?
Yeah, so there have been there are some reports demonstrating the potential difference in the phenotype of disease. For example, in Japan, there are more perianal diseases in Crohn's and more isolated ileal disease. But as long as I know, there aren't that many studies showing the difference in terms of efficacy and safety from the clinical trials.
We always feel that, like, being in Scandinavia, for instance, the body mass and the height and everything is much bigger than in the Japanese population, but this will not change the treatment because most of them are now standardized and not weight-based, or do you see any differences there?
Yeah, so like the only thing that I just came up with is like the Japanese patient may suffer from like those dependent like adverse events. For example, like upadacitinib, the dose per body weight is actually like bigger for Japanese patients.
Now we are getting into certain treatments. Are there any completely different treatments or something which you use? In my mind is, for instance, because I have been doing this for quite a long time, apheresis, which is created in Japan, and I think it's still used frequently in Japan, or has there been also a change?
Apheresis isn't very widely used anymore because of the access to many other advanced therapies. But we have oral alpha-4 specific inhibitor, like small molecule, available, which can be used only for the induction for UC patients.
And only for UC patients, also not in Crohn's disease patients?
Not in Crohn's.
One other thing I always liked was the use of calcineurin inhibitors. So our center did also a lot of studies and was publishing a lot of studies with tacrolimus in patients with ulcerative colitis. Is this still used in Japan? Because I think it was driven, and I remember one of the big studies was from Japan.
Yeah, so tacrolimus was actually discovered in Japan. So now it's officially indicated for UC patients, and it's quite widely used, like probably more often than cyclosporine, especially in acute severe UC patients with low albumin, especially.
Yeah. You mentioned that you have a huge variety of drugs now available. And this is a problem in I think all over the world, prioritization of these drugs. So what is used first, what is used later? And I just recently came across that there are also Japanese guidelines similar to ECHO or ACG guidelines, AGA guidelines. So how is the prioritization of different drugs, or how do you do it with your own patients?
Yeah, so that's a very important question. But like, what's different is our guidelines just list all the advanced therapies in parallel, no sequencing. So like that means we have more freedom in terms of sequencing or like selecting the advanced therapies. We can use like P19 as a first line, for example, or JAK inhibitors as a first line as well. So once the drug is approved, there is no restriction in terms of the sequencing the drugs.
And you have all of these drugs available. So you have we have now 3 P19 inhibitors available. You have all of them, or
like all P19 inhibitors are available for both UC and Crohn's. We have S1P receptor modulators as well. Yeah.
So you really have everything. I would for the real final part, because you mentioned this earlier, you have a lot of or more perianal Crohn's disease, and my personal opinion, perianal Crohn's disease is the most difficult part of the game, because patients do not respond that well to the drugs. We do not have the clinical trials. We have only one dedicated clinical trial
Right.
with infliximab. The others are just subgroup analysis. So how do you manage the patient with perianal Crohn's disease? And just give us an estimate. So how many patients of your Crohn's disease patients will have fistulizing perianal disease? Is it 10%, 20%, 40%?
Yeah, so in terms of just the prevalence of perianal disease among the all Crohn's disease patients in Japan, it's like around 40%.
Oh, that's really high.
Yeah, but it doesn't have to be very refractory, non-complicated, but it just the incidence is like 40%.
And what is your treatment pathway?
So that, but like for perianal like Crohn's disease, if the perianal disease is active, I still prioritize like anti-TNF, especially infliximab in combination with thiopurines, even though we have freedom to use any of the advanced therapies. But this is, as you said, that's the most challenging scenario and a phenotype of Crohn's disease. That's why I rely so much on the evidence.
We have at the moment also subcut infliximab available. So what are you using? Using IV induction is still necessary, but do you keep the patients on IV or do you switch to subcut?
Actually, subcutaneous like infliximab hasn't been approved yet.
Okay.
It's
okay.
we are running the Japan specific study.
The only part where you don't have the choice.
Yeah.
And the final question I really would have, I had just recently discussion with Jean-Fred Colombel, and he said when there is a really complicated patient with perianal fistulizing disease, he's exactly doing what you are doing, thiopurine, infliximab, and then also giving a bit of antibiotics. Are you also doing this in certain patients?
Yes, exactly, especially in combination with the discussion with surgeons.
Yeah. Taku, I think this was really great. I thank you so much. I learned a lot about the Japanese healthcare system, about the specifics of reimbursement and the differences in the management of patients, monitoring and also treatment. This was wonderful. Hopefully we can repeat it in the near future because I think we have many more topics to discuss.
My pleasure.
And I thank all of you just for listening. Stay tuned. We will have another episode of IBD Essentials in 2 weeks. And if you like us, again, remember, send some likes, ask for new topics, and hope to see you very soon. Thank you.